suggest, of course, it is fungal infection, like opportunistic. We talked about flora. The moment I talk about opportunistic, you should start thinking of commensal, you start thinking of normal flora. And in this case, we are just separating out with the rest of the community in terms of what are the major players. So when we talk of opportunistic mycosis, we talk of either candida or non-candida. These are the two terms, and we kind of have evolved over time. When we say candida, so most of the time we mean candida albicans. And I'm going to spend a lot of time on that because that's the #1 fungal infection that you see in the whole world. When we say non-candida, we talked of Cryptococcus neoformans. And when we say non-candida, non-Cryptococcus, we are talking about Aspergillus and Zygomycetes. These are the 4 important opportunistic infections that we're going to discuss, right? The other important thing is that I still have used that pneumocystis carinii for AIDS infection, but recent textbooks want us to call it pneumocystosis jirovecii. So this is like some of the technical terms that if you see both, they pretty much are the same thing. Now, like bacteria, opportunistic mycosis depends upon the invasiveness of those particular fungal infections. Bad news is that they have increased over the past 2 decades. And of course, the reason is they're high-risk groups: blood and bone marrow transplantation patient, solid organ transplantation patient, major surgery, especially GI surgery, AIDS, neoplastic disease, immunosuppressive therapy, advanced age, premature birth. So you can see we are making a lot of progress in this group, and they are surviving for a long time. But at the same time, they are vulnerable to not those skin infection, but invasive mycosis. Now, as I said, the most well-known cause of opportunistic mycosis are Candida albicans, Cryptococcus neoformans, and Aspergillus fumigatus. Okay. In terms of annual incidence, the invasive mycosis due to the pathogens I just mentioned happen to be 72 to 90 per million for Candida, and 30 to 66 for neoformans, and then 12 to 34. All these statistics are important in terms of the healthcare burden on the CDC and the health industry. So CDC thinks that whenever you come across any particular problem, even if it is septicemia, or if it's something that you cannot figure out, they want to advocate physicians and all diagnostic people think fungus. So that's what they say, think fungus. Fungus is coming up. It wasn't the case. So whenever we look for any infection, and that is posing a diagnostic or therapeutic challenge, we should have a heightened clinical suspicion of fungi, because if we miss that, we're not going to treat it, and then we'll end up in trouble. So what is happening is that now we are making sure that we not only isolate, but identify this organism and initiate the antifungal therapy. So that's the whole point in terms of invasiveness of disease. Now, as I said, candidiasis basically is a disease caused by Candida. Is the most important fungal infection that we see. And if you look at the nosocomial bloodstream infection, Candida species are the 4th most common cause. The only other players that are there, of course, are bacteria, right? So they are even causing more problem than even gram-negative pathogens. And remember, when we talked of gram-negative pathogens, we thought of endotoxin. So if you look at statistics, these are very important. Now, if you look at your textbook, there are hundreds of species of Candida. Only few are implicated, and we'll talk about those few. And 90 to 100% of the cases that we normally see are Candida albicans. So that's a good news. So we kind of working towards those 10% plus minus that we want to hold responsible for some other Candida. 95% of all Candida bloodstream infections are by 4 species. So C for Candida, right? Albicans, glabrata, parasitosis, and tropicalis. Just like what you call Starbucks kind of special coffee thing. You know, so you have to remember these are important. Albicans, glabrata, parasitosis, and tropicalis, and we see them clinically a lot. Okay. Now, of all these things, one of the most is like an emerging star. That's what the textbooks say, and this is glabrata, that is coming as the major cause of bloodstream infections. Right. The other problem with this particular fungi is that it has intrinsic and acquired resistance to antifungal drugs. That's a scary part. If a person, and you remember the story of those, I think upstate New York or wherever, Boston, where they had contaminated the syringes with fungi. So that's a big problem. You're injecting it to the system, and it always will be a very serious risk for causing fungal infection, especially if it remains untreated. So if you were asked, what is the name of the fungi that has intrinsic capability to resist the current antifungal therapy, the answer is Candida glabrata. Now, if you look at the morphology, it is an oval yeast-like, size is 3 to 5 micrometer, and if I tell you it's 3 to 5 micrometer, what cell of the body is of the same size as Candida? If I was to ask, which of the following cell is exactly the same size in the human body? Who taught you physiology? Yeah. Huh? Say that? Blood cell, red blood cell, 5 micrometer, red blood cell, 5 micrometer. Anyway, so size is important in terms of, I just explained the barrier thing, okay? Now, the other important thing for species of Candida other than glabrata makes pseudohyphae and true hyphae. Albicans form germ tubes and has a thick wall, conidia. So these are the conidia that kind of disperse up in the atmosphere. Now, if you look at the structure over here, budding yeast, typical morphology, pseudohypha, and then you have hypha over here. These are the typical presentations of Candida. One last concept before I take it in detail tomorrow. What has happened is that something called phenotypic switching. Does anybody remember what kind of switching we were talking? Huh? What did you say? What? Let me finish the question. I didn't finish my. I said, you said class switching? Yeah, class switching for the antibodies, right? So this one is there wasn't an extra credit question though. I have to announce that ahead of time. Phenotypic switching basically is different than class switching, but that was for the antibody production. What is happening in this concept is that if you culture Candida, they typically have smooth, white, creamy, domed colonies. So they have a dome there, and then they can undergo phenotypic switching, where one of the strain of Candida change reversibly and then it comes like in a different. So they can come like fuzzy, hairy, and change the form. So that's important for us because it may mislead us, for example, in terms of diagnosis. And then it also mislead us in terms of treatment, whether you're going to go for treatment for mold or treatment for the yeast. Okay, so I'll take it up from here tomorrow, and we'll continue with the Candida. And also keep in mind that